My background is broadly public health, but initially my training was in children's physical activity and health. So I spent about a decade working with schools to do research to try and improve physical activity and nutrition of children. I worked just up the road in Loughborough in the National Centre for Sport and Exercise Medicine for 5 years, and then before that the School of Education at Durham. So I didn't really have a good understanding and appreciation of EEDI or issues relating to minority participation in health research since moving to Leicester and working in the Centre for Ethnic Health Research. And you can't get away from these issues if you want to engage effectively and work within our organisation and work with communities and different stakeholders unless you embed yourself within this area. And I've had a rapid upskilling over the last 5 years, and particularly during COVID, of course, shone a huge light on inequalities, and we had quite a considerable role to play throughout the pandemic, whether that was generating data and evidence on ethnic health inequalities, whether it was trying to improve representation of these groups within COVID work, or representation on SAGE and independent SAGE and direct inroads to policy. I'll start off with a little bit about the centre before getting into how we work with ethnic minority populations, and that's focusing on a specific group, but of course I think some of the principles are applicable to other underserved and minoritised groups. And Naina was one of the key founders of our centre 7 years ago in 2016, but it was born out of academic clinicians who'd been working within the city of Leicester and seeing patients from diverse communities and all of the health inequalities they were facing. And the core of our vision is to try and reduce health inequalities by working critically with local communities, public and patients who are experiencing health inequalities. But we also work with community and voluntary sectors, researchers like myself, health and social care organisations, companies and so on, sit on advisory boards. We have at the moment we've got about 15, but I think it's going up in the next couple of weeks. We're hiring outfacing and research staff. That critically includes community engagement officers who go out and engage with diverse communities, which is at the heart of what we do. And the nice thing is that some of them are co-opted, so they have a part-time role in, for example, working in a Bangladeshi community centre for a couple of days a week, and a couple of days a week they work with the research team. So they have membership of that community, they have real understanding, and that's really important. We're building off the back of COVID to try and get core funding and national centre status. We're always trying to get money to retain our critical mass of staff and continue our good work. So that's a little bit about the centre. As I said, we collaborate with a wide range of organisations, and that does include companies who come to us for advice, for us to sit on advisory boards on how to diversify, whether it's the workforce, whether it's the populations that are being recruited for clinical trials. And a lot of our work is focused on trying to develop alternative ways of engaging with different populations. And the gentleman here asked about, different modes of disseminating work, and Naina discussed that. And I've got one particular example around prostate cancer that I'd like to highlight in just a moment. We just go back to that other slide. It's okay. We also deliver training programs for researchers, clinicians, other stakeholders working in this area, and there are two key types of training that I want to highlight in a moment. We have various toolkits and equality impact assessment tools that I will highlight. A big area that we've been working on through COVID that Naina highlighted was underrepresentation of ethnic minority groups in health research, and this is a battle for us. And I just want to highlight a piece of work one of our team did 6 or 7 years ago. We face an uphill struggle in diversity in clinical research in terms of gender, age, across all of the protected characteristics, but particularly in ethnic minority representation. So this is a review, a systematic review where you search electronic databases for certain pieces of literature. In this case, we are interested in glucose-lowering therapies in type 2 diabetes, and looking at, well, what was the population of the study samples these were trialled in? Were they primarily white European, white British? So of the 12 studies globally that we managed to find, for those studies, and the issue if you're trying to dig around into ethnicities, it's not very well recorded or reported in the first place. So for 8 of the 12 studies, we could only extract information. Of those 8, 7 of the 8, so the majority of them, underrepresented the South Asian ethnic group relative to the UK diabetes population who are affected by diabetes, relative to the South Asian population who are affected by diabetes. And it's important because South Asians in particular have a higher risk compared to white Europeans or white Britons of being diabetic, and the same for black Caribbeans and black African, although the risk differs ever so slightly. Not surprisingly, we concluded, well, you can't necessarily then apply the evidence generated in these trials to the wider population, but it's a little bit more complicated than that. And I'll try and articulate that in the next slide. The way diseases develop in some cases differ between ethnic groups, and critically some treatments and the way that they operate and whether they're efficacious and effective may differ between different ethnic groups. And a nice example we always give is this one in the bottom left around warfarin. Well, as I understand it from our clinicians, lower doses of warfarin are required to be effective in Asian populations compared to white patients. So if you're generating evidence on whether it's therapies, whether it's public health prevention programs on a very homogenous population, their applicability to our wider public is obviously going to be constrained. As well as of some of the biological processes, if we think about how healthcare is delivered and people's experiences of healthcare, that's very different. And when numerous surveys come out year after year that show, like the race disparity audit in 2019, people from different backgrounds experience healthcare in different ways. It could be straight up discrimination, it could be historic poor experiences of healthcare and access to clinicians, and that therefore breeds mistrust. But the way people navigate the healthcare system is obviously going to be, in some cases, different by ethnic groups. So we need to take that into consideration if we're developing and trialling new ways and new systems of doing healthcare. Guidelines, nice guidelines dictate so much that clinicians do, and in some cases they're based on evidence which is very homogenous. Not just epidemiology in trials, but patient and public involvement in some cases. So guidelines could be differentially benefiting populations if the evidence it's been generated on is homogenous. So as I said, we try and work with researchers and different organisations, and some of the barriers that we find to trying to improve participation from diverse communities, I've highlighted some of them here. The first is around this term cultural competence, and we're trying to move away from this idea that you can, through training and building skills, be competent in a culture. Well, because cultures are fluid and ever-changing, I think humility might be a better term. But having the knowledge, the awareness, the understanding of even ethnic health inequalities, other cultural issues and so on, affects how you engage effectively with different communities, and therefore if you can't engage effectively, you'll perhaps have less competence and confidence and be able to ensure that we're recruiting these populations to our work. And I was certainly, and I'm still on that journey to becoming competent, for want of a better term. Grew up in the New Forest in a small market town that was 96% white British. I moved to Exeter, which was 93% white British. We lived and worked in Worcester, which was 96% white British. Durham, which was in the 90s. And until moving to Leicester, I couldn't tell you much about, for example, what Ramadan was, or all kinds of different cultural practices, religions, and so on. So many researchers are like me, unfortunately. There's a lot of understanding and work to be done. So we work with research teams. Second point is trust. Time and time again we hear about trust. And of course, the vaccine examples during the pandemic, trust was a big issue. Like Naina said, re-PPI, this takes resource, funding and time to be able to do this, and funders need to recognise this is a slower process. we it takes longer. And so we build trust in lots of different ways. We convene community partners panels. We reach out to people who are trusted members of communities, whether that's faith leaders, whether that's community leaders, people that have inroads and trust within the communities that we're trying to access. So that's one of the things that we try and address. And then just going, sorry James, back to that slide, there are always the logistical issues. Study inclusion criteria can often be particularly narrow and exclusive, and in some cases that is pragmatic. If we think the obvious example being language, resource to translate materials, or in some cases practicality if you're running a trial in an A&E department to deliver a drug on the spot, like sort of one of the examples you were giving, do you have time to bring in a translator to do consent on the spot? There are lots of logistical issues, and we work hard on trying to address those. We have a good translation team, and I'll talk about that in just a moment. So those are three key issues that we see time and time again. It's much more complex. We try and base our work on decades of community experience, but we also look at kind of what works best from the academic evidence. And this is a review of the literature we did on behalf of NHS Digital. And these were studies where they tried to implement strategies to improve inclusion and diversity within clinical trials. You might not be able to read the writing there, it's a little small. One of the first points was that cultural humility and competency training of the research staff, of the allied health professionals, whoever were delivering on the programmes, the interventions in the trials, building the community partnerships, which links in with increasing understanding and trust of communities. So initiatives to try and again, I've got some of them listed here. I'll have a little community advisory boards, patient advocates doing good PPI work, engaging with community members, leaders, groups and organisation, direct outreach to communities, taking a personalised approach, so not mass emails, spending time on the phone in between repeat follow-ups, having staff that are multilingual, that look like the population that they're working with and sound like and speak the same language. And we have a very diverse group of staff that speaks to that within our centre. Communication, whether it's tailoring dissemination, whether it's thinking about how we write consent forms, we try and tailor our communication strategy. So in some cases, rather than having a written piece of paper for consenting someone to a trial, it might be more appropriate actually to have somebody to be able to translate and do it orally on the spot. If it's, for example, someone who is older from a South Asian community that doesn't have a family member with them, then rather than having written translated materials, we try to do things orally. So we think about tailoring our communication strategies. What else have we got on there? We've got logistical barriers. So it could be thinking about caring responsibilities. Another group who surprisingly are underserved in some clinical research are working age women. So, you know, if it's, I'm losing my train of thought there. Anyway, we're thinking about travel, thinking about some of the barriers that constrain participation is obviously, you know, really important. So on to the next one. What do we do? So we have bespoke researcher training programmes, and they fit into two broad areas. One is effective community engagement, which covers all communities, and we work to upskill people around the Equality Act, learning about different protected characteristics, and practical approaches to working with diverse communities. Once people have gone through that programme, we make it a little bit more complex and add in cultural competency, and those can be delivered virtually, in person. They're offered at multiple time points throughout the year. They run over 3 half-day sessions, I think, at the moment. So we deliver training programs to researchers and organisations. We invest a lot of time in local communities to build trust, not just to do the research. Our vision is to try and reduce health inequalities. So we run health improvement programs that are appropriate for local communities, and one is walking cricket for older South Asian gentlemen who want to engage in physical activity. They want to convene in a community area to be physically active, to have that's social time with their peers. So we've invested time and money in that for the sake of it, because it's good for the community. But of course, later down the line, in 6 months, a year, when we want to run a trial in a certain area, in older South Asian men that might have prostate cancer, then we've got links to the community. So we try and give back, and we try and develop community members, be that sitting on patient and public involvement panels, training them up to be patient advisors, to go and advise all across the country on other projects. We do try and develop community members. The translation, which I mentioned, we place quite a lot of focus on that and alternative communication methods, and we focus on conceptual equivalence, not just linguistic equivalence, because a lot of the medical nomenclature isn't necessarily directly translatable between languages. So we spend a lot of time on concepts. And I think it's either the next slide or one after. Go to the next one, I'll come back to training. This is an example of how we try and develop alternative methods of engaging communities. So prostate cancer, higher prevalence in Black African, Caribbean men than white Britons or white Europeans. And we worked with some of our community engagement officers to think of a way, how can we commune this community, commune this age group, bring them together to talk about something dry like prostate cancer. We know they're reluctant to go to the GPs to talk about this, reluctant to talk about health. How can we make inroads? And one of the suggestions, dominoes, seems to be particularly liked in this community at this age group. So we held a number of community events where we convened these older African Caribbean men around dominoes, held health fairs, disseminated information, got them talking about their issues, and tried to encourage them to seek prostate screening. And we had significant kind of social actors in the community, Chris Gale, their famous West Indian cricketer, to provide testimony, because of course testimony from other community members is really powerful. And again, we saw that through vaccine messaging, and Naina mentioned some of the work she did there. And I've got a video, hopefully it will play, and that much better articulates what I was trying to say. Yes, yeah.
This is Pam's.
It's Pam's video, yeah. So Pamela Campbell-Morris was a community engagement officer who did excellent work for many years with Naina and colleagues in this area. So I think if you click in the middle, it might play. If not, we can move on. And
it looks like it's doing something.
Yeah.
Pam sadly passed away.
Yes.
And it's been a huge loss, because I was at her funeral and there was about 800 people there. She was just so well loved and respected in the community.
Yeah.
Her life was working to the betterment of the African Caribbean community.
It's okay. It's yeah, don't worry. It would go through to YouTube, so you may not have. Yeah, and I think you were mentioning about Pamela. People who have those long held. It's okay, James. We can go on to the next.
It's on YouTube though.
It is on YouTube. Yeah.
Slides afterwards.
Yeah, of course. Yeah. It was just a small ITV segment, and there's other animations that articulate it much better than I could. Another, besides training around cultural competency and effective community engagement, we worked really hard with our research teams and external organisations to try and implement an equality impact assessment process. And it's a toolkit plus training, and some of that is online and accessible through our centre website, which gets teams to think about the positive, negative and neutral impacts of their work, of their innovation, of their product on all communities across the 9 protected characteristics in the Equality Act. And if we think about a positive impact of a new innovation, well, that would be, in our case, addressing health inequalities. So you might be trying to develop a programme that reduces the gap between South Asians and white populations in diabetes risk. That's a positive impact. A negative impact would be the implementation of a product or an intervention that may increase that gap. And in some cases, like I was talking about, unintended consequences, you could, for example, I don't know, develop an app or some kind of digital health innovation which is accessible obviously to a certain proportion of the population, but perhaps not those from deprived communities with low digital literacy and you know, low access to technology and resources. That's perhaps not the best example, but we try and get teams to think about the positive, negative, and in some cases there are neutral impacts. It's okay actually to be exclusive in work sometimes. Sometimes a study or product requires that you focus on women between 40 and 50 genetic screening for a particular disease, because that's the particular unmet need in that case. So we think about, you know, the proportionality of it. It is okay to be exclusive, but as long as you think about, you know, and are aware about how the process impacts people of different ages, whether they're, you know, living in deprived areas, whether they have the time to, you know, if you're running a study and it's within the working day and you have to travel there and it requires you to engage in, you know, I don't know, exercise, and you're not, you know, able-bodied and so on and so forth. So this is a really good process. We've only started rolling it out in the last couple of years to our researchers, and it does challenge them. So if you're interested, I would advise you, have a look at that. We also have a range of different toolkits on the next slide. So we've got our own in-house toolkit for trying to increase participation of, and I need to highlight Black, Asian and minority ethnic BAME. That term has been phased out as a consequence really of the pandemic, shining light on all sorts of things, including terminology and language around ethnicity, and we've published some work on that. That's a side point. We've got a toolkit there. There are others, the include ethnicity toolkit. If you're involved in clinical trials, we help develop some of that, and that gets teams to think about who you should be involving in the work, where, when, why certain activities are done, and that's a great toolkit that I would encourage you to look at. We also have further resources that are specific to certain disease areas and other populations, and they're all on our Centre for Ethnic Health website. And I think that's it really. So yeah, happy to answer any questions. That was quite a lot, so I appreciate a lot crammed in there.
Does anyone have any questions or comments?
I thought the community engagement stuff was brilliant. So a lot of the academic teams, research teams that I work with, it is one area they struggle with because they're so good at the research and they're so good at their scientific area or the research area, and then to go out into community groups, whether it be the general public, whether it be policy, industry, it is totally new to them. It's something they've not been trained to necessarily do. And within the institute or team, there isn't anyone that is able to do it. And the other thing that they also struggle with is that, they shouldn't have to always do that. Like you said, it's sometimes better to send, I always say to research teams, who's the closest person to the stakeholder?
Yeah.
Can we be that close person? And sometimes we have to say, no, we shouldn't be that person because we're a different colour, speak a different language. Who is closer? Who has that trust? Who has that relationship? And how can we find that person? That's really interesting to work.
Yeah, no, I absolutely agree. And we have a pathway of supporting researchers like myself and like you're saying, just there, that have less experience of this, not just linking with community, not just delivering training, but linking with those trusted community members. You know, I'd never stepped in a Gurdwara in my life, apart from, you know, prior to 5 years ago. So being able to have someone to come in there with me that knows the religion, knows the cultural practices, knows, you know, where to take your shoes off, can speak different languages, can articulate, can help allay fears around certain, you know, whether it's injectable therapies in diabetes, you know, hugely important. And I'm still learning this, and I think it's a long process, isn't it, to become.
And all the different medications and what they have in them, how they're made. Then you've got to think about faith groups and cultural and societal norms. It must be super complex.
Yes, yeah, oh, absolutely, yeah, very, and the intersectionality of different characteristics as well is something that,
I think it's just it's complex, it feels complex, but I think there are some personal values that people recognise, and even if you don't know, it doesn't so much matter as whether they can trust you. And do you come across as honest and transparent? And do you undertake to reciprocate? Will you give feedback? It's those kinds, because this is value-based work. And I've been into organisations, as you said, where you don't know anyone, or communities that have been really horrifically treated, particularly by mental health services, etc. And I've gone in to work on a mental health project, and I faced a barrage of anger. And I don't try to justify anything. I just say, I'm just trying to do my bit. And I need you to engage just to move this on a bit. I totally get where you're coming from, but I'm not going to do that. This is who I am. And I think it is about being upfront and clear. And you do get transactional researchers who think, I've got to do this. Maybe need a couple of people around the table. Let's just go and get, and let's just afterwards don't need them, and they won't hear from them, and that's what's caused the mistrust, and that's why it's got to be values-based work.
Because these stakeholders that you're talking about, they have to be at front and centre of the research throughout the whole narrative of the research project, and they have to be the hero in the conversation, the narrative as well, and not just the sideline, add-on, bolt-on whilst you do your research. No, and the good thing is that ultimately you want the same thing. People want to be healthy, and they want their families and to be healthy and their friends. But you have to navigate that together. It's a network activity, isn't it?
And what you said earlier about equitable, I think when you engage with people initially, it's about what can you do in terms of the power dynamics in meetings, but also what can you do to enable people to be on the same level playing field. Sorry, I'm getting my words mixed up. On the same field. Is I often say, right, let's talk about diabetes. Let's talk about this. Do you know much? What do you want to know? And it's about what they want about diabetes, dementia, whatever. And then we move together. But it's not about what I want to tell you about my research and what I want from you. It's turning that power dynamic and the content and the processes of that engagement.
Yeah, putting them in the centre of the conversation rather than the way
And that's what I mean by equity as well. It's got to be throughout.
Cool. Almost a sort of a reverse mentor concept.
Yeah. And from this
thought of what do they care about, what matters to them, what do they value. And I love it how you the West Indian men, they love dominoes, they love cricket, and then you put that as a motivation to have a good conversation with active listening.
Yes, absolutely. And I think, right from the start, and again, your example, Carl, I can't remember exactly what it was where you went out to clinicians and they said, we're not going to use it. Yeah. So a lot of our projects are driven by the end user, where we don't really go in with an idea. We try and think about the unmet needs of the community right from the off. And we often find we get hundreds of requests every year from academic organisations, and they say, we've got 10 days or 2 weeks before the funding deadline, we need to have a diverse PPI panel, and you must get that all. Absolutely, or we need this group involved, and there's no reason why, they didn't think why or who's it benefiting.
They did a lot of work with prostate cancer, with football stadiums, and what was interesting is that they were going to put the testing clinics sort of where people couldn't see, so they could discreetly do it. But they said they got a better response doing it publicly, because when people saw their mates doing it, they actually went in droves, and they got loads more men getting tested actually on the outside of the ground.
Absolutely, yeah, and that's a great example of
Pam
this
did a
ethos.
comic book as well.
Yes.
To take back into schools.
Yeah.
And she agonised over the language that was used, and there's one particular rude word that she agonised over whether it would be allowed or not. But it was about the way people speak. on the ground. And yeah,
Yeah, it was in patois, wasn't it?
It was
Always
in
a part.
patois.
Yeah.
Yeah,
So
it was all in patois, but there was one particular word that, you know, she agonised over. But if that is the way that people speak, that's the terminology that people use, then yeah, you know, she decided to go with it.
Bravery, isn't
Yeah.
it? You have to be quite brave
Yeah.
with this, otherwise it just gets diluted and just
yeah.
gets missed. And
And I think it's just always have the end user who is going to use it, because actually if you're applying for, say, NIHR applications, Innovate UK, you need to have a layperson description. So one of the challenges we have, like I mentioned that we've had over 100 companies, actually to articulate what you are doing as a company, the product or the service. If I always do, my granny's 88 and I always do it the granny test. If I explain to her what I'm doing and she understands, that's it. Now that is the level that you need to be doing, because not everybody is an academic, not everybody is a clinician. So it needs to be sort of like, I've got a background in communications as well, but we always used to pitch it sort of the intelligent 12-year-old. So if you can sort of say what you're doing to sort of the intelligent 12-year-old and they get it, that's really what you wanted to do. And if and sometimes there's so many people that and companies that are actually not articulating what they're doing, and literally if you're going for investment VCs or applying for sort of the NHR, like, you're not going to get the funding if you can't say what you're doing. So that's why it's so important. But also the early engagement. And I'd say as well, I think it's use services like the RDS and go and speak to Ash and the team at the Centre of Ethnic Health, because it's almost sort of that early engagement. You can do that sense making to actually, have we got something here, and get that feedback, but then also doing the case making to actually sort of build the sort of the value proposition and the sort of make a more robust application.
It always makes it much more compelling. You know, the patient voice and testimony at the heart of it is always much stronger.
But like we've supported one or two companies actually, one company specifically, and she'd actually had a ileostomy and had it reversed, but actually we engaged with a couple of the companies and to give insights to them. They're actually doing some of the things already, but she gave them some quite interesting sort of, I don't say hints and tips, but just sort of, this is what happened, this is what you need to have a look at, and actually some of the reasons why they didn't go down that route as well. So I think like the pharma industry may call it patient centricity, but you can call it sort of PPI, or it all needs to be sort of thought about. Are there any other questions for?
I'm just going to say it's a lot of unintended consequences. The tyranny of the participant information sheet, where let's take an egregious example. You've got an anti-cancer drug for prostate cancer. It's a 23-page information sheet, and actually your patient groups will most going to benefit are not be English speaking.
Yeah.
Certainly aren't going to slog through a 20-page. Are they really going to participate? No. And your results end up not generalisable. Then again, at the ethics committee, we've had this do something else, and they go, well, actually, those are the rules. Come up with a better excuse.
Yeah, I agree. We're fighting against regulation
Regulation.
internally and externally to be able
It's
to
also
implement
recruitment methods as well.
that. Yeah.
You know, the amount of
Consent
times.
to take, consent to commit, consent.
No, it's just sitting in GP surgeries or in hospital clinics and trying to recruit members of different ethnic communities. It doesn't always work, you know. And if you go out into communities and work with the Centre for Ethnic Health or, you know, community organisations and try to recruit participants for your research that way, it does work. It does work well, as long as you're working with the community development workers, the volunteers, to publicise your study. And you've worked with them fairly early on and got their trust, so they recommend that. But one of the things that we used to do is advise researchers to work on storyboards or videos instead of that sheet.
So, super. I realise we're nearly at time, maybe a couple of minutes over, but I was just going to just signpost one or two slides that we've put together just to sort of. I realise we've got quite a holistic presentation today. Just give me 1 second, because pardon? No, it's okay, thank you. There is one slide I just want to share with everybody. It's just to sort of keep in mind. So. The topic area is very, very broad, and I actually used a little bit of AI, so I went onto ChatGTP and actually put in the title and ask for sort of keywords, and it spewed out a whole list of different things then put into a word cloud. But really, putting together this event, very much the topics are interlinked. So if you are, I realise that the audience is a little bit different today, but if you are a company, or if you are an academic, if you are scaling or developing a product, that there's different things that you need to sort of think about, very much sort of like from the internal focus and the external focus, as we've said. I'm just going to go back to the slides here, because I know it has been mentioned, but this is sort of the MHRA legislation, and we'll share all of these slides around that Carl mentioned specifically earlier. But also thinking around sort of CSR, so people will use sort of corporate social responsibility, but this is actually what's termed as sort of the 3 pillars. So it's around reputation management, risk management, and sort of stakeholder influence, and how you the 3 intersect and how you can sort of use that. One of the things that I know we haven't sort of really mentioned, but what I just did want to sort of actually around sort of ethics and everything else like that. There's GDPR and there's the Data Protection Act. And we have sort of mentioned sort of protected characteristics and other things like that. So if you are a company and you are scaling, you do need to sort of think around sort of things like this. And actually, if you need to do sort of data protection impact assessments, or actually how are you going to handle people's data. And then there's just a few lists here of around sort of standards to keep in mind. So there's the ISO standards if you are wanting to sort of be sustainable and environmental. And I'm going to really highlight, actually, there's one standard that was developed by the BSI, and sort of if you are doing sort of Innovate UK applications, they do look at sort of, it's called PASS 414, it's sort of around responsible innovation, and there are actually free to use sort of frameworks on there that sort of cover quite a wide aspect. If you are developing an innovation, how can it be more sustainable? How can you sort of work that? And then actually there are some legislation and statutes to sort of keep in mind. So we have mentioned sort of animal testing, so that was the ASPA, and that's from 1986, but then that's grounded on the 3 R's framework, what's been around sort of for around 50 years. That's really sort of looking at the replacement, reduction and refinement of animal testing. We've got the Human Tissue Act of 2004, and there are a plethora of MHRA regulations as well that I'm not going to go into. But I think just sort of 2 other acts and legislation that's to keep in mind. There's the Equality Act of 2010. I know has been mentioned, but then there's also PECRA as well. So if you are trying to recruit people to trials or other things like that, you can't actually keep bothering them through lots of texts and other things like that. So yeah, just want to sort of thank you for all of your time today. And if anybody has any other final comments or questions, we'll be downstairs so we can network. But thank you for your time today, everyone.
Thank you.
Thank you.